So if the definitions and classifications of pulmonary hypertension have changed, should we also be rethinking the way we diagnose this condition? Well, the answer is yes and no, and let's talk about that a little bit. So usually we start with our regular tools to evaluate dyspneic patients: an EKG, blood tests, PFTs, ABG, cardiopulmonary exercise testing. Our standard screening tool is echocardiogram, and it's our most important one, but we have to understand how to use it to be able to make it most effective. VQ scanning to sort out who has vascular obstruction, CT scanning to evaluate who has significant pulmonary parenchymal disease, and right heart catheterization to diagnose this condition. So let's talk about our current algorithm. This has been revised slightly with the new World Symposium guidelines. So first, we have patients, and we see them, we assess them, we talk to them, we find out their risk. And I would argue that's the most important part of this whole algorithm. If we don't detect who's at risk, we will never go to the next step. Our pivotal point in testing is the echocardiogram. It can be absolutely normal, or it can have features that are concerning for pulmonary hypertension. And the VQ is a dividing point, driving us towards the workup of CTEPH versus the workup of PAH. And we need to know how each of those tests fit in the algorithm to make them useful. So let's talk about that echocardiogram. This is simple. You see this 4-chamber view, a very big right ventricle, right atrium, a pericardial effusion. This is clearly someone with advanced disease. But we don't want to meet people at this stage. We want to meet them with more subtle findings. You can see this advanced findings here with this D-shaped left ventricle and enlarged right ventricle compressing that function with the pericardial effusion. Again, this is more of a slam dunk, but many times we're meeting people who are mildly symptomatic, and we're trying to sort out with that echocardiogram which direction to go. So how do we use the echo with the most effectiveness? We look at the echocardiogram and we look at multiple parameters, and we put that all together to determine if the patient is likely to have pulmonary hypertension. We look at the TR jet velocity. Is it normal? Is it intermediately elevated, or is it significantly elevated? And we put that together with echocardiographic features of pulmonary hypertension to determine, is the patient low or intermediate or high risk for PAH or PH in general? So what are those risk features? We can look at the ventricles, we can look at the pulmonary arteries, and we can look at the inferior vena cava and the right atrium. All we need to have a positive is 2 categories, 1 in each. On the ventricles, we want to know how big the ventricle is. Is the right ventricle bigger than the left ventricle? And is the septum flattened? I showed you an example of that. Clearly that ventricle was enlarged and the septum was moving to the left side, opposite of normal. The pulmonary arteries, is there notching? Is the acceleration time less than 105? Is there early diastolic regurgitation, or is the pulmonary artery enlarged? When we look at the inferior vena cava, is it dilated? Does it change with respiration? And is our right atrium enlarged? If we're seeing these abnormalities, at least 1 in 2 groups, then we increase our risk based on echocardiogram.